Hi, my name is Angela Roberts, and this is my Nursing 4423 Evidence-Based Practice Final Project Oral Presentation for Lindsey Wilson College. This is a PowerPoint of a literature review which I conducted in the nursing topic of facility-acquired pressure ulcers, a need for more frequent repositioning. Let's get started. Our first slide covers a need for more frequent repositioning. While the standard for repositioning patients within my facility has held a highly reputable percentage of facility-acquired pressure ulcers of 2 to 3%, there has been a recent increase to 4%, which is concerning to all members of the healthcare team and bears a great significance on my current nursing practice. Facility-acquired pressure ulcers are a topic of great concern in the healthcare setting, and according to Palfreman, affects 3 to 25% of all patients. There is an anticipated increase in prevalence due to the aging patient population, or the baby boomers, coming on. And this has raised a question as to whether the current clinical practice guidelines should be altered to provide a higher level of care to improve patient outcomes. The most effective preventive measure against facility-acquired pressure ulcers, despite all new technology, is manual repositioning of patients who experience decreased mobility. The current standard of practice suggests that turning and repositioning patients take place every 2 hours and is the acceptable practice in all healthcare settings. However, this clinical practice guideline has been questioned as to whether it should be altered to provide a higher level of care to improve patient outcomes. A literature review was performed with results that revealed a justified need to improve these current clinical practice guidelines, making repositioning more frequent. I'm going to go over the methods that I used for this literature review. It was undertaken searching the EBSCO host database using the keywords pressure ulcer prevention, repositioning, and costs of pressure ulcers. Full text and scholarly peer-reviewed journals within the last 5 years were the selected limits used to narrow the search to the most recent research articles desired. From this search, there were a total of 9 peer-reviewed scholarly articles selected. All of these articles were dated, and none have been published since 2011. Review of these articles revealed there are current evidence supporting the need for more frequent repositioning of our patients, and identified 5 specific supportive categories. Among those categories include the etiology of pressure ulcers, prevalence of facility-acquired pressure ulcers, financial effects, current clinical practice guidelines, and a need for increased frequency. And we'll go through all of these one by one. The first we're going to discuss is the etiology of pressure ulcers. Palfreman in 2016 identifies the pressure ulcers typically occur over bony prominences such as the sacrum, hips, and heels. Peterson, Gavenstein, Schwab, Van Oostrom, and Caruso in 2013 state pressure ulcers occur when increased pressure on skin and tissue exceeds the pressure in local capillaries. Research by Cherry and Moss in 2011 point out that pressure ulcers develop as a result of tissue damage from outside pressure and obstruction duration. Prevalence of facility-acquired pressure ulcers is our next topic. And according to Moore, Kalman, and Posnet in 2013, almost 1/5 of hospitalized patients are suggested as having an existing pressure ulcer, with the greatest number of those developing after admission. Research provided by Meddings et al. In 2015 suggests that facility-acquired pressure ulcers are unfortunately quite common, with a prevalence rate of 1 million to 2.5 million annually within the United States. Peterson et al. In 2013 states that pressure ulcer prevalence rates have been reported as high as 12.3% of patients within all facilities, 22% of those specifically occurring within long-term acute care facilities, and 8.8% to 10.3% being the highest in the adult intensive care units. Our next topic is financial effects, and Peterson et al. In 2013 provides research that states the management of full-thickness pressure ulcers can cost nearly $70,000, and that the pressure ulcer treatment for the United States exceeds $17 billion annually. More recent research conducted by Meddings et al. In 2015 estimates the cost of healing one single pressure ulcer ranging from $5,000 to over $151,000, depending on the severity and staging of the ulcer. Peterson et al. Explains the Centers for Medicare and Medicaid Services have identified pressure ulcers as a quality measure, and they are no longer reimbursing accrued patient expenses that have resulted from a reasonably preventable condition which occurred while receiving care. Palfreyman suggests there is a more recent statistic come to light that says 95% of pressure ulcers are all preventable. The current clinical practice guidelines. The fact that facility-acquired pressure ulcers continue to be a problem warrants one to review current practices and determine if there are more effective prevention measures that should be implemented. Spriggle in 2011 determined that pressure magnitude is managed by support surfaces and body posture, while duration is managed by turning and repositioning, along with frequency to redistribute pressure. Spriggle also suggests preventive measures against facility-acquired pressure ulcers need to be centered around reducing the exerted pressure on tissues and surrounding skin so that tissue damage does not result. As outlined by Palfreyman in 2016, the most universally accepted practice for pressure ulcer prevention is turning and repositioning the patient every 2 hours, and this standard of care is currently supported by the Agency for Healthcare Research and Quality. A need for increased frequency. Current research suggests current intervention measures need to be adjusted and repositioning frequency should be increased. Peterson et al. In 2013 assessed 23 bedridden patients, all at risk for pressure ulcer formation, and received routine positioning as part of their care. The findings from this study clearly determined that all 23 patients exhibited areas that were always at risk. This suggests that the current standard of care is not sufficient enough, and the repositioning practice needs obvious improvement. Another study performed by Moore, Kalman, and Posnet in 2013 evaluated the effectiveness of two separate repositioning routines in the reduction of pressure ulcer incidence amongst a population of older hospitalized patients. Their research findings determined the prevalence rate of new pressure ulcer formation among patients to be significantly lower in the experimental group, offer better patient outcomes, and provide a cost-effective preventive measure for facilities. This suggests a need to invest in more aggressive preventive measures. One final study was conducted in a surgical intensive care unit to determine if a specifically designated turn team would be beneficial in the challenge of facility-acquired pressure ulcer formation reduction. The research findings provided by Steele et al. In 2013 determined there was a reduction of facility-acquired pressure ulcers from 42 down to 12 found in patients. These findings were dramatically inductive that this intervention decreased their incidence of pressure ulcer formation, and the majority of stage 1 and stage 2 pressure ulcers appeared to be highly preventable with this aggressive intervention measure. The implementation to practice. The review of all the previously discussed studies are linear with the QSIN competencies and identify evidence-based practice, patient-centered care, and quality improvement as ideal patient outcomes from increasing the frequency of repositioning. The limitations to practice. The current standard of practice for repositioning patients every 2 hours derives from unknown etiology. It is thought to have begun its implementation from the routine practices of Florence Nightingale. However, this uncertainty could be considered a limitation to evidence regarding the acceptable standards of frequency. In conclusion, while the current standard of care for repositioning every 2 hours is supported nationally, there are several studies that suggest an alteration to these standards would improve both patient outcomes and patient safety. There are documented cases which suggest more frequent turning repositioning regimes reduce pressure ulcer prevalence. Any preventive measure implemented within a healthcare facility should be patient-centered for optimal improvement in patient outcomes. Sving, Idval, Hogberg, and Gunnenberg in 2014 suggest healthcare organization leaders should establish routines on different levels that support evidence-based pressure ulcer prevention, and nurses need to assume responsibility for bedside care. The anticipated impending increase in the elderly patient population demands a review of systems and implementations already in place. If there are more aggressive preventive measures, improved patient outcomes and improved patient safety could be provided. This could be accomplished with more frequent repositioning and turning of our patients. And this is a list of my references. Thank you so much for your time.